I'm privileged to introduce a very good friend of mine, Dr. Tannimale Jagannathan. Dr. Tannimale Jagannathan is a senior consultant, an experienced obstetrician who's currently working in Thomson Hospital and also is working in Avicenna Women and Children's Hospital. He's one of the principal trainers of the intensive course in obstetric emergencies. He's actually the Malaysian representative to AFOG. He's very experienced and he's going to talk to us about shoulder dystocia. Can we prevent? Can we predict? Over to you, Dr. Tani.
Thank you, Mones, for your kind introduction. I would like to thank ONG Society for us to discuss on this topic, shoulder dystocia prediction and prevention. Okay, I recently had a patient. So I was involved. I am a principal trainer in intensive course and obstetric emergencies. I do a lot of shoulder dystocia training, so I was confident. But this is a Indian lady with a diabetic, very influential lady. She wanted a vaginal delivery. So I estimated the birth weight is to be 3.8 kilos to less than 4 kilos. So I discussed about the risk of shoulder dystocia, and she wanted a vaginal delivery. She understood perfectly, but she came in a spontaneous labor and she progressed without much intervention. And I was laughing, and she's asked her that she's going to push and she's going to deliver. I was expecting a normal delivery, no instrumental delivery. The head, she was pushing more harder, and she delivered, but I couldn't deliver the shoulder. I tried Macrobert's position, suprapubic pressure. It didn't come up. Most of the time you will succeed, but I didn't succeed delivering the baby. Then I attempted delivering the posterior shoulder because the left shoulder was the posterior shoulder of the fetus. But I inserted my left hand to do a delivery of the posterior arm, but I failed. I was shocked, and I had a very two good midwives, like a sumo wrestlers. They were giving a fundal, not fundal pressure, the suprapubic pressure, as well as performing Macrobert's maneuver. But I failed, then I was struggling, then managed to do reverse hook screw maneuver to deliver the baby. At that juncture, I was thinking whether I'm able to predict shoulder dystocia accurately and prevent it or not. Look at the incidence. In 40,000 deliveries, the risk of shoulder dystocia is 0.6%, whereas the risk of brachial plexus is 13% and fracture is 5.1%. But why does the shoulder dystocia happen and what it can lead to? Most of the time, the brachial plexus C5, C6, C7, and C8 and T1 rises between the neck muscles and it comes out. Most of the time, due to shoulder dystocia, the head is delivered. The anteroposterior diameter of the pelvis is 12 centimeters, where the shoulder diameter is much larger than that. So the anterior shoulder gets obstructed in the symphysis pubis. So strong downward traction causes damage to the brachial plexus. Most often, injury is a neuropraxia. That means stretching it often recovers within few months. Sometimes it causes rupture. It can result in permanent injury, or even in spite of surgical repair. Sometimes it causes nerve root avulsion completely. So if C5 and C6 is injured, it causes Erb's palsy. Most of the time, Vater's deformity. So that, or if it is a C8 and T1 nerve roots are injured, it can cause Klumpke's palsy. So when I looked at the literature to predict, is there any possible good studies to show that we can able to predict the shoulder dystocia and prevent it accurately? When I was during my training time, I knew that it was totally unpredictable and unpreventable. When I look at the literature in the last 20 years, most of the literature is retrospective, case controlled, cohort studies, not much prospective trials done on this area of preventing and predicting shoulder dystocia. So let's look at, so I thought it'd be useful to look for answers for 6 questions. How useful are the risk factors for shoulder dystocia in prediction? Can shoulder dystocia be predicted accurately? What are the ultrasound parameters could be used to predict shoulder dystocia? Does induction of labor prevent shoulder dystocia, or cesarean delivery can prevent shoulder dystocia. Effective way to prevent shoulder dystocia. So let's move on to the first question. How useful are the risk factors? Nesbitt and et al. Published in 1998. What are the common risk factors? Is macrosomia, birth weight of more than 4 kg. This retrospectively looked at the babies of macroscomic babies of more than 4 kg. Maternal obesity, one of the factors. Maternal diabetes mellitus is one of the risk factors. Large for gestational age are the risk factors. But in a pregnancy outcome, in a normal gestational diabetic mothers with the normal general population, we look at retrospective cohort of 61,000 deliveries compared to 841 gestational diabetic mothers. 50 to 60% of shoulder dystocia occurs in babies less than 4 kg. So in general, when birth weight is 3.2 kilos, there's a 1% risk of shoulder dystocia. If the birth weight is 3.5 kg, the risk is 3%. But you know the majority, 50 to 60% occurs between less than 4 kg. So is there any difference between the infants of the diabetic mothers compared to the macrosomic babies born to the non-diabetic mothers? So this group of people published in early 1998, so anthropotic differences in macrosomic infants of diabetic and non-diabetic mothers. They after assessing 50 odd babies, they looked at the babies of the diabetic mothers have larger shoulder diameter, the arm circumference and the limb circumference are much larger than the counterparts. Then they have a decreased head circumference compared to the shoulder circumference. They had a larger shoulder diameters as well. So because of upper extremity fat deposition in the upper part of the chest, that prevents the shoulder from having an engagement diameter to negotiate into the pelvis and rotate itself to undergo a fetal rotation to deliver easily. So the differences body composition and weight distribution may explain the risk of shoulder dystocia in diabetic population. So what are the useful risk factors? The useful risk factors 8 for counseling are, say, they group this retrospective analysis. They looked at birth weight, babies born with 4 to 4.25 kg, 4.2 to 4.5 kilograms, 4.7 to 5 kilograms. One arm is non-gestational diabetic mothers and gestational diabetic mothers with instrumental delivery. In retrospectively, if the baby's birth weight is more than 4.7 to 5 kilos, the mother is a non-diabetic, your risk of shoulder dystocia is 21%. Whereas if the mother is gestational diabetic and requires an instrumental delivery, the risk of shoulder dystocia is around 35%. If the baby is 4 kilos and mother is not gestational diabetic, the risk is only 5.2%. So this is very useful point to consider when during counseling mothers antenatally. So next, move on to the second question. Can shoulder dystocia be predicted accurately? Lewis and et al. In 1998, they looked at positive predictive value in a retrospective outcomes in a case control population. So when they looked at it, maternal obesity more than 90 kilos has a positive predictive value of 32%, whereas excessive weight gain was more than 20 kilos during the pregnancy was 25%. So whereas the other positive predictive factors were very low in that group of population. So other group of people looked at the other antenatal risk factors for shoulder dystocia. They are generally quoted postdated pregnancies, advanced maternal age, platypoid pelvis, multiparity, excessive weight gain, and previous macrosomic baby, and shoulder dystocia has 10 to 20% risk of recurrence. So let's move on to the intra-bottom risk factors. What are the risk factors for shoulder dystocia? Basket and et al. Published what are if a prolonged pregnancy has a risk factor for shoulder dystocia 3 times more. Prolonged second stage of labor has a 3 times more risk of shoulder dystocia. Mid-cavity rotational forceps deliveries has 10 times high risk of shoulder dystocia. Increasing birth weight, macrosomic babies, And they proved that strong downward traction of the head significantly results in brachial plexus injury. Next, what are the risk factors and fetal outcomes? They published in British Journal of ONG in 1996. Most of the time is a retrospective case control study where they had 69 babies born with shoulder dystocia and 138 matched controls. They also said that the operative delivery have high risk and the biacromial diameter has a high risk and short head circumference were predictable factors. So most of the risk factors, and this is the reputable study used for intrapartum and postpartum detection of intrapartum and antenatal event prediction of shoulder dystocia. They tried to develop an algorithm to predict a shoulder dystocia. It is published in 2010. They calculate the risk screening module for shoulder. They looked at 4,028 retrospective analysis of singleton pregnancies. They looked at 4 criteria: birth weight along with dependent antenatal factors, birth weight with antenatal and intrapartum factors, all independent variables excluding birth weight. In that study, the incidence of shoulder dystocia was 0.6%. 40% of the babies were delivered less than 4 kg is the important. Birth weight was the important risk factor. When you look at the 2 risk factors were the antenatal risk factors, birth weight and maternal height were the independent risk factors. Intrapartum, they looked at birth weight and instrumental delivery correlated well. So in conclusion, they looked at antepartum and labor calculation of the risk of shoulder dystocia is possible, while it's greatly hindered because of inaccuracy in weight estimation. The shoulder dystocia cannot be predicted with sufficient accuracy, allowing for universal screening. So we know that biggest hindrance is estimating of fetal weight antenatally. Next, we look at what are the ultrasound parameters which should enable us to predict the shoulder dystocia. In Jasri and HL published in Obstetrics and Gynecology in 1999, they used as macrosomia prediction or predict macrosomia using ultrasound, fetal ultrasound, abdominal circumference of more than 35 centimeters. There was nearly 500 babies. They used the abdominal circumference more than 35 centimeters, and 93% of the time they able to predict macrosomic infants, and this group 13% had a risk of shoulder dystocia. So babies with abdominal circumference more than 35 centimeters were able to predict shoulder dystocia. But this is recently published in 2014 in a white journal where they use anthropometric measures to predict risk of shoulder dystocia. Unfortunately, this also retrospective study in 12,000 vaginal deliveries. The incidence in that population was risk of shoulder dystocia 1.14%. They looked at the various diameters, head circumference, abdominal diameter, but they used a femur length and all those estimated fetal weight. They looked at abdominal diameter minus biparietal diameter, and the difference is more than 2.6 centimeters. It has able to predict the shoulder dystocia. It has a sensitivity of 8.2% and specificity of 98.8% with positive predictive value of 7.4%, very low. And they used an abdominal circumference of more than 35 centimeters, also performed worse, and the positive predictive value is only 2.6%. But they recommended combination of estimated fetal weight, maternal diabetes, gender, abdominal diameter minus biparietal diameter more than 2.6 centimeters is a reasonable estimate of individual's risk. So in conclusion, ultrasound fetal anthropometric measures appear not very useful, but abdominal diameter minus biparietal diameter is a relevant risk factor useful in risk stratification. Shoulder dystocia cannot be effectively be predicted. So back to square one. So this is published fairly recently in 2020. Universal third trimester ultrasound screening using fetal macrosomia and prediction of adverse perinatal outcome in a low and mixed population, where the aim was they used as estimated fetal weight and abdominal circumference. And estimated fetal weight of more than 4 kg had a sensitivity of 22% predicting shoulder dystocia and the positive likelihood ratio of 2.2. When they use estimated fetal weight more than 4 kg with abdominal circumference more than 36 centimeters, it improves slightly the sensitivity of 50% predicting a macrosomic fetus. So they found they can suspect large for gestational babies is strongly predictive of risk factor of delivering large infant, but however it is not accurately predictive of shoulder dystocia because ultrasound estimation is not very accurate and enable us to prevent shoulder dystocia. So let's move on to the fourth question. Does IO, induction of labor, prevent shoulder dystocia? This is a randomized controlled trial, induction of labor versus expectant management for large gestational fetus in a randomized controlled trial, is published in Lancet in 2015, which is carried out in Europe in 19 tertiary care centers. They looked at induction of labor with expectant management from 37 weeks to 39 weeks. The primary outcome is shoulder dystocia, fracture, and brachial plexus injury. In the induction of labor, there's 409 women and 413 in expectant arm. The mean birth weight for induction group was 3.8 kilograms and expectant group was 4.1 kilograms. So in the risk, shoulder dystocia in the induction group was 1% and the risk on the expectant group is 4%. So the relative risk of shoulder dystocia in the induction group is very much reduced, whereas the cesarean delivery is similar in both arms. With the same group of people, they looked at the Cochrane literature, this study, and along with the two other studies, they looked at the gestational induction of labor for near term for suspected fetal macrosomia. So this is nearly 1,190 in the study arm, where they're assessing efficacy of induction of labor between 37 to 40 weeks suspected fetal macrosomia. The risk of cesarean delivery is similar. The risk of instrumental delivery also is very much similar. Whereas the risk of shoulder dystocia in the expectant group is 68 per 1,000, whereas induction group was 41 per 1,000. So the relative risk of shoulder dystocia prediction is 0.6. They could prevent 40% of shoulder dystocia. And the risk of fracture, any form of fracture, clavicle or humerus, in expectant is 4 per 1,000, in induction is 2 per 1,000. The relative risk of fracture also is low. So the quality of evidence is moderate, the quality of evidence is low. So in conclusion, the Cochrane systematic review in 2016 published that induction of labor for suspected fetal macrosomia has not shown to alter the risk of brachial plexus injury, but reduces the birth weight and shoulder dystocia and fractures. So it's somewhat useful in preventing macrosomia. So next, we look at the planned birth or near term for improving health outcomes of pregnant women with gestational diabetes, not for macrosomia, for gestational diabetes and the infants. So this is nearly 425 women, induction with the expectant management. There's no difference between risk of cesarean section. There's no risk of instrumental delivery, and they are unable to prevent any shoulder dystocia. The risk is very much similar and large for gestational age babies. So in conclusion, there is insufficient evidence to clearly identify the difference between health outcomes of women with gestational diabetes mellitus. So next, move to effective delivery in diabetic women. If diabetic mothers who are taking insulin, they looked at elective delivery in a Cochrane review published in 2010. So this is an induction arm. This is an expectant arm. There was roughly around 200 population. So the risk of cesarean section was not statistically different, but the risk of macrosomia is very much reduced. The relative risk is 0.56. That means they're able to 50% risk of prevent shoulder dystocia. So in conclusion, they were unable to predict shoulder dystocia, but they were able to reduce the risk of macrosomia in this group of patients. So induction of labor somewhat helps. So what does we look at the next question is a prophylactic cesarean section. That means to do a cesarean section to prevent shoulder dystocia. American College and Royal College so published this. The numbers need to say one permanent brachial plexus injury. If the birth weight ultrasound birth weight is 4 kg, the number of cases required is 2,300 cesarean section costs 4.9 million. Whereas if 4.5 kg, I need to do 3,000 cesarean section cost more. But if it's 4.5 kg and GTM, you need to number of cases required to do cesarean section 443, it costs 9.39 million. So in conclusion, American College recommends against delivery before 39 completed weeks of gestation. It discourages protein induction of labor, elective cesarean delivery for fetus with estimated weight of more than 5 kg, women with diabetes, where estimated field weight of 4.5 kg, they recommend cesarean section. So how do we improve one's delivering skills for good outcome? We know that simulation training and drills improves team communication, improves performance of individual maneuvers, reduce the incidence of brachial plexus palsy associated with shoulder dystocia. Here, this is our own Malaysian data, 5-year data. We looked at Malaysian healthcare professionals. There are nearly 609 numbers, where 400 of them are midwives, 128 are medical officers, 55 are specialists, and 26 consultants over a 5-year period. So this is the pre-skill and the post-skill. So the pre-skill score are generally very suboptimal. The post-skill score are much better. That means it shows that generally the participants' pre-skills are very poor. It improves the skills. I would ask participants to concentrate on the delivery skill of the posterior arm. If we look at the midwives, they were very poor. They improved tremendously. We look at the medical officers and the consultant arm, more pre-delivering skills of posterior arm were suboptimal, which improved very much after training. So as I mentioned, most of the trials are retrospective case control trials. There's a big baby trial currently in progress in UK, which is expected to complete in 2022, where they enroll nearly 4,000 women and compared to 300 parallel cohort who declined randomization. It's a randomized control trial, how the babies are delivered. This will give us some answer. So in conclusion, can shoulder dystocia be predicted and prevented? Shoulder dystocia predisposes the fetus to risk of permanent brachial plexus injury. That's true. The risk factors has extremely poor predictive value, but if used in combination like birth weight, ultrasound birth weight of more than 5 kg, abdominal circumference more than 360 millimeters, mothers are diabetic, then these risk factors enables us to predict or somewhat guide us in counseling and educating people and prepare us that you're going to face shoulder dystocia. Shoulder dystocia is totally unpredictable and unpreventable obstetric emergency. Systematic approach to this problem is mandatory. Simulation training like intensive cause and obstetric emergency improves the outcome and shoulder dystocia management of shoulder dystocia. Simulation training improves the individual's documentation. Thereby, you're able to have a good risk management and essentially avoid a litigation. Thank you.